This is Ebony Porter-Ike, and I am the host for the Doctor's Lounge. I'm very honored today to have Dr. Lipman, Dr. Angelina, and Dr. Leslie Matthews in the studio today. Our topic for today is something that's near and dear to me. It's all about African American women's health. If you are an African American woman, you know that this is a hot topic. This is a topic that many of us have talked about in girlfriend talks. We talk about it online. We talk about it on YouTube and so many different places, but many times the conversations don't leave from there. Many of us feel obligated to keep the topics to ourselves because, again, most people don't believe that there is disparity in the healthcare industry as it relates to African American women. And today we're going to talk about it. I think it's very important that we have the doctors that we do have in studio because unlike me, none of them are African American women. So I can talk to them directly about how we feel as African American women as it relates to our healthcare and our healthcare issues. It's also important because less than 1% of physicians are African American women. So the likelihood of walking into a doctor's office and your doctor looking exactly like you is slim to none. I remember being pregnant with my daughter and I searched high and low for African American female OBGYN. And she was able to service me. I had to drive 45 minutes to see her, but then thereafter giving birth to my daughter, her practice went out of business. So again, I know it's very difficult for us to find physicians that actually look just like us. So we need to open up the dialogue and have the conversations with our doctors about how we feel and to find out what's really fact and what is really fiction. Okay, so I want to start off by talking about something that is one of the hottest topics that's all over the news right now. The FDA is proposing a ban on perms. Perms, relaxers, whatever you want to call them. Many of African American women started receiving perms in their hair, relaxers in their hair, at the tender age of 4 or 5 years old. It was something that many mothers and grandmothers did to make the hair more manageable for a child. So if you started receiving perms or relaxers at the age of 5 years old, and then you're 20, 30, and 40 years old, and you're still receiving or actually applying that product in your hair, you have now put this poison into your body for over 20, 30, 40 years. What most people don't know as African American females, when we put the perm in our hair, you can feel something. It smells really bad. It burns once it's on your scalp for a long time, and if you don't take it off immediately, it will actually cause your hair to fall out. So at that time, as a young girl, I knew immediately something must be wrong with this product. But we continued to use it and use it and use it, and over the years, it has caused much damage in our bodies. I want to ask this question to the doctors. What are your thoughts around the perms, relaxers that African American women have used for so many years, and the fact that as a young woman, I was 10, 12 years old, I knew then that something was wrong with the product. Did you guys not have that conversation behind closed doors about the perms and relaxers and how damaging it could be to African American women?
Well, this topic comes up almost on a daily basis in my practice as I treat women with uterine fibroids. And so we've known for a long time that what makes fibroids grow, what's increasing women's risk to other cancers, breast cancer, uterine cancer, ovarian cancer, is estrogen. And so these hair relaxers have a lot of ingredients which either mimic estrogen or hormone blockers. And what's interesting about this FDA proposal is it doesn't talk about those ingredients. So there's a lot to unpack with that. The main issue that the FDA has is with formaldehyde. Formaldehyde is used in embalming, and that's probably what you were experiencing. It's that agent, but that's not the only issue here, but it's certainly a long overdue step to hopefully they will ban formaldehyde because, as I say, it has no business being in, the products, the beauty products, the relaxers, any products that potentially could get into our bloodstream.
Any other doctor?
Yes, formaldehyde is also in the nail polish that ladies had on their hands also. We do not talk too much about these FDA products that are being banned in trauma critical care surgery because I'm on the other spectrum from Dr. Lipman and Dr. Angelina. It's like the patients I'm dealing with, they can't talk usually, they're unconscious, or they have a traumatic brain injury. So we're trying to save the life at that time, and so we do not really go into those type of discussions.
Dr. Angelina?
Well, like Dr. Lipman mentioned, there's a lot of other products that FDA need to be mentioning and working, not just putting warnings about, because right now I think it's just a warning, but actually banning them. So if we look at the European system, where a lot of the carcinogens, known carcinogens, are banned, here just a discussion. So we're like years behind the rest of the world. Things like parabens, right? Like a lot of preservatives that in a lot of the products. Skincare, hair products are also similar to estrogen and increase potentially breast cancer, uterine cancer, and fibroids. And there's a lot of other preservatives. So it's not just formaldehyde, even though formaldehyde, like you mentioned, I only had my hair done once. But it does burn. You cannot breathe. It increases risk of, oral pharyngeal cancer. It's really a disgusting product because, again, I don't do much for my hair. But now as my daughter, who does have that very tight curl as being, half Nigerian child, now I'm actually questioning, if the hair lady comes into my house, what is in that product? Is there chemicals in this product? I'm not putting chemicals in my child. But, I am, I guess, more aware of this, and I'm not under the social pressure to straighten my hair, which, again, in African American community is not just because of the ease of taking care of the hair. People who know what they're doing know how to brush the hair. It's also social pressure. Oh, you must have straight hair to look more professional, which is not true, but it's that cultural, right, discrimination, I guess. So there's so many other things in this subject that we can talk about forever, and none of these things were addressed in medical schools, because that was your question. Have we talked about it somewhere? I don't think we ever talked about it in medical schools. It's not taught.
No.
We're not taught about carcinogens like that, not in a common household products. I mean, we talk about things like people trying to drink drain cleaner. Yeah, in surgical world we have that, but there's no topical carcinogens that are discussed in any of the medical school, at least not when we went to school. And so same thing about, just as you said, finding a healthcare provider that looks like you, who understands what you're going through. That's also not discussed in medical schools.
So let me ask this question. Are most of the carcinogens that you're speaking about, are they mostly found in beauty products, or are they in multiple products?
Well, there are in other products besides, beauty products, but certainly that's where you're most concerned about, the exposure. And hopefully, this proposed ban will be real, because we've known for a long time the effects of formaldehyde, and it's not only the people that are using the product, but it's the salon workers. The exposure for a long period of time can't be good for you. There's just too much evidence available. I mean, the study that led to all of this was done over many years, and was over 30,000 women were studied, because fortunately the uterine cancer rate is really low. So you need to study a lot of people to see if there really is that risk. And they found that there was. It was over twice the risk for people that relaxed their hair versus those that didn't. And so, as Dr. Angelina mentioned, in our practice, many more women are wearing their hair more naturally. So it's becoming less of an issue. But for those that want to relax their hair, it still remains that question. And they did show that women that reduced their amount of hair relaxer use, if you used it more than 4 times a year versus those that used it less than 4 times. So if you have to relax your hair, try to do it less often. That does help your risk. But fortunately, the risk is very low. It's for uterine cancer. It sounds scary, but the risk is actually higher for some of these other risk factors like obesity. You're much more likely, if you're obese and sedentary, to have a higher risk for these cancers than if you use hair relaxers. So the focus really should be more about obesity and increasing people's activity and exercise.
I think, though, the fact that the conversation, though, did not happen until 2023. And I'm just going back to when I was a child and remembering my hair and feeling its scabs sometimes in it, and the smell that permeated because of the perms. It just seems to me that the conversation didn't happen because it was African American women. And I think many of the complaints that we may have had many times goes unheard or unseen. And we still don't know the fullness of what this product has done to African American women, because if you're saying 95% of African American women will experience fibroids in comparison to their counterparts, that is an alarming number, and it isn't something that one should take lightly. I remember when I was pregnant with my daughter, I had a fibroid that was competing in the size of my daughter. And so I was a high risk because the fibroid could have smothered her in my stomach. And when I was giving birth, if I had not known about that fibroid and I was back in the 1800s, I would have died during childbirth because the fibroid blocked my cervix. And so I questioned many times, was that related to years and years of perms? Because unlike what you said, 4 times a year, realistically, African American women perm their hair every 4 to 6 weeks. So that is something that is known. It is something that I think we can't ignore. And I wonder how many people have needlessly died specifically because of that. But one of the things you also mentioned, Dr. Lipman, is the weight and how important, because I think in the African American community, many of us believe that it's okay to be voluptuous. It's okay to carry a little bit of extra weight. It's part of our community. It's part of what people expect for Black women. But with that comes the increase of diabetes. With that comes the increase of high blood pressure, fibroid issues, and so many other things. What are your thoughts on that? Is it a myth that African American women actually just naturally carry more weight than our counterparts? Is that a myth?
Okay. Well, no, nobody actually carries any more weight. You actually have to eat food, put food in your body, and not exercise and balance your diet and balance exercises. Also, being obese takes 12 years off your life. That's research. And I've had two brother-in-laws and a close friend. They were all over 300 pounds. Neither one of them made it to the age of 62, Social Security retirement age. So it is a very real problem in the African American community. Over 30% of African Americans are obese.
So,
Well, if you look at body fat by race, African American women do have the highest body fat by race. Asian women the lowest. And so when we talk to women, about their fibroid condition in the office, there are certain things that you can do that can affect your fibroid outcome. And there's certain things you can't do. You can't affect your genetics. But we know that once fibroids arrive, they grow with estrogen. And so we impart an anti-estrogenic strategy. So if you can lose excess body fat, because estrogen is stored and produced in body fat, you'll improve your outcomes. It's not only good for your fibroid outcome, it's good for your cardiovascular outcome. So it's a win-win. If you can try to avoid hormone-rich foods, you can diet, lose excess body fat, you can definitely improve your fibroid health. You lower your risk for these estrogenic tumors, breast, ovarian, uterine, and improve your quality of life and live longer, cardiovascular-wise.
So, in my view, since I actually treat obesity in my practice, Obesity is a very complex disease, and it's both environmental, lifestyle changes, and genetic. So yes, there are certain populations are more genetically prone to obesity, but it does not mean that it's always person's fault. So I think in America, the way everything from history was created, right, back in 1800s, I think some people were genetically basically engineered to be more prone to keep the weight on. And back in those days, a person who could keep more weight on did potentially survive longer, right? Because starvation was more of an issue and everything like that. Now that we're here, where food is not as much of an issue, at least availability, not in America, the genetics are still the same. So some people are more prone to, once you gain that weight, to keep that weight, right? The weight set point. And the issue now in America is the socioeconomic issue, right? Lower socioeconomic classes will have more issue with obesity. They have less access to healthier foods. They have less access to, that we have those deserts, right? Like no healthy food stores. Food, there's lack of education. What is good food? We have to do it every day. When I tell patients you have to eat healthy, so fried chicken is okay, I'm like, we have to start going back to like grade one of what is a healthy food for our body, what do we need to survive. So there is a lot of cultural differences and accessibility to both education and proper health care for patients, because also the food deserts also will have the doctor deserts. It comes together. So I do think African Americans definitely prone to obesity. Obesity definitely leads to 13 different type of cancer, increased risk. So not just estrogenic based, but there's others. The treatment for those cancers then becomes an issue because, again, accessibility issue. And there's also lack of education about obesity as a disease, and also lack of sometimes family support, because from the very beginning, people were taught, or you're just lazy, just eat less, work more, right? Work out more. But that's not true. You need help. You need medical help. And when the person finally reaches that line and says, I'm going to go to doctor and ask for help, sometimes even the family says, oh, you're just being lazy. You're taking easy way out. Somehow you have to work harder to get health care. So there's so much to uncover in this one little topic. And we can do...
It's important because this is the other thing, Dr. Angelina. Behind closed doors, African American women, when they go in and have their annual physical and they are weighed, and their doctor will tell them, okay, you're 20% overweight or whatever the case may be, what you don't know is most of your patients are ignoring you because they're saying in the back of their mind, oh, that number is not for African American women. That's a number for Caucasian women. We can add on an extra X amount of numbers because we naturally have bigger bones, or we're naturally... That is a conversation that happens a lot.
It is correct.
It is correct?
So that's why BMI is no longer being recognized by American Society for Obesity and Bariatric Surgeons. Even though we still use it because there's not a number, BMI as a healthcare measurement, as a number, was created not for healthcare purposes. It was made up using a whole bunch of like European white men. So it did not really apply to women. It did not apply to any kind of ethnic group. And so if you look at, let's say somebody from, I don't know, Vietnam, down South Pacific, whatever, Asian, tend to be smaller bodied person. For them, BMI of 27 is actually like obesity, where we could offer gastric sleeve, technically speaking, because all of their comorbidities at that number would be way higher, like diabetes, heart disease, heart attacks, strokes, and everything. With African American person who tend to have more muscle and more bone, slightly higher number would be acceptable. So yes, we have to look at weight distribution, at proportions between waist circumference to hip circumference. How do you carry your weight, right? The belly fat is more dangerous than the hip fat. So yes, if somebody has a bigger booty, that's completely fine. We're not gonna go after that.
But so why don't we talk more about that? Why, when a black woman goes and have her physical, she's told you're obesely overweight,
You have to be very sensitive about how you approach that, especially with some women. I was a big proponent of getting your weight down, and actually, I had complaints made against me to the administration that I was talking about their weight. I said, that's a health issue. When somebody's morbidly obese, I was just telling her she needed to get her weight down because she's having arthritis, over 300 pounds. I said, this arthritis is not going to get better until you get your weight down. And
but Dr. Matthews, not to cut you off, but many physicians will just say, get your weight down, but they don't give you steps or advise you. Just go see a nutrition.
We had dietitians
well,
that's refer them to. We didn't just tell them to get your weight down. We referred them to a dietitian out of the clinic.
What I will tell you is that most dietitians that we were referred to were overweight themselves when we walked into the office. So if I walk into the office and the dietitian is overweight herself, I'm not likely to listen to her feedback. I just, one of the things I think you said, Dr. Angelina, that rings is that I don't know that people hear the cry about that. It's not just about, I can't control what I eat, or some things are just genetically inclined, but it does not remove the health issues that are tied to that.
Food noise is real. So in my practice, as you know, I don't just send you out to a dietitian. I give you medications, or I give you surgery for weight loss, and I definitely counsel and give you options on both. So in my office, you're not going anywhere. You're getting treated, whether you like it or not. But it is a real issue.
But that's if they can afford the treatment.
Hopefully they have insurance, or yes, we can look at the long-term financials and show that this will help.
Mm-hmm.
But even now, I get patients. I did a consult a couple of weeks ago with an 18-year-old girl who was calling about the medications, because we do the GLP-1 medications. And of course, surgical. She didn't know anything about surgical treatment at the time. And I was like, what was your last physical? And she's like, I just saw my pediatrician, my regular doctor now, last week. I'm like, okay, and what'd she say? She's 400 pounds. And she said, doctor said, all the labs are normal, everything is fine. There was no conversation about obesity, there was no conversation about the diseases, there was no conversation about potential risk 20 years later. Because she might be fine for the next 20 years. She might have trouble conceiving a child, she might have fibroid issue eventually, and then things will start really adding up, right? So that's when I had a conversation with her about surgery, about medications, about everything else. And yes, there's definitely accessibility issues. So right now with the medications available, the GLP-1s that truly work very well, well, people who don't have insurance and they cannot afford the medication, and it again puts people in two different classes. You can pay for the medicine, or you cannot pay for the medicine. And who cannot pay for the medicine are probably the ones who need it the most. So I think conversations are happening with people, but we still have accessibility issue. And you have to find the right type of doctor. So you have to get educated about the disease and the risks, make a decision, go to the doctor who can actually treat the problem, because a lot of doctors still refuse, and they just keep telling you, go eat less and exercise more. And we know from studies that's not enough, because there's a genetic component, there's a food noise, there has to be a medication or surgery to help.
And what is food noise?
So food noise, I have not heard this term before, because I think people didn't recognize they had it until it disappeared. It's one of those things. So food noise is basically literally people who do have high risk for obesity, usually are, they constantly thinking about food. Literally their brain is constantly busy thinking about food. They're eating now and they're thinking what I'm gonna have for lunch. They're eating lunch, what I'm gonna have for snack, and what I'm gonna cook for dinner. The food noise doesn't stop. And so a lot of those people, once they got hold of GLP-1 medications and first time had it, all of a sudden it's like you have ta-da moment where there's no food noise and you have time to think about all these other things in your life.
Let me ask this question to the other doctors as well. Are you guys familiar with this GLP-1 medication, which is the Wegovy and the semaglutide? What are your thoughts on that? Because there's been a lot of arguments that this particular product is being used and is taken away from diagnosed diabetics. So what are your thoughts about non-diabetics using GLP-1?
Well, I think the jury's still out on that personally. And so I would just exercise caution. No drug is without risks and side effects and adverse effects. And we have a lot of our patients actually taking it, some of which I think really need to be on it based on their weight and if they have type 2 diabetes. For those that aren't diabetic, but just want like a quick weight loss fix, I think we should exercise a lot of caution in those patients. And so because we don't have the long-term effects, we know some of the side effects, usually gastrointestinal, but there's a lot to learn in this. And so I would caution people that just want to try to find a quick weight loss fix to, and that's where there's a lot of enthusiasm for it, because people always want the easy road. They want the magic pill, the magic bullet. And there are people in our society that really need this medication and should be on it. For those that are looking for the quick fix, I would be much more cautious about recommending their use of that.
Okay, Dr. Matthews, I know you, Dr. Matthews.
Use with caution, but as long as you're closely monitoring it and your patients, so I have no problems with patients using it, or if their physician is keeping a close watch on them.
Okay. Dr. Angelina, I knew what part your ears
you
went
know
up
I'm going to get in this.
when you heard the quick fix. So that has been because I know that was one of the huge conversations that Oprah just recently had. I don't know if the doctors, if you guys have seen that. It caused a major conversation around the globe about the quick fix and an easy way out was the answer.
I'm totally fine with magic pill, and I'm totally fine with the easy way out. I'm a surgeon. I like quick fixes. If I can fix it surgically in one day, please come. I'm all about quick fixes. And medication is not a quick fix. It takes a lot of hard work from the patient standpoint. I mean, you're going to poke yourself with a needle once a week for the rest of your life, most likely. And it has to come with lifestyle changes, diet changes, exercise, and other things you have to watch out for. Also, the medication officially FDA approved for obesity and overweight. So semaglutide has 2 marketed names: Ozempic for diabetes, semaglutide for Wegovy is officially for weight loss. Mounjaro, the new generation of the drugs, right now officially approved for diabetes, and it's waiting for its obesity FDA approval probably this quarter, before end of the year.
So Dr. Angelina, have you heard anything about someone taking the medicine and then one day their body becomes immune to the effects and they no longer lose weight?
It's a possibility.
And they just reverse and they just begin gaining weight back?
So everything is possible. Again, the class of medication been out for about 20 years. So we do have enough studies on it to say for now it's safe. We've been having good new clinical trials coming out, cardiovascular risk reduction by 20%, diabetes obviously reversal, not eradication because it can come back if you stop the drug, same as obesity, and many other good side effects. Now, as far as reversal, if you stop medication that was treating your chronic condition will come back. If you've been taking medication for a long time, it has its limits, right? Statistically, semaglutide, you may lose 17% of your body weight after long-term use, over a year, and tirzepatide, which is Mounjaro, maybe 23% of your body weight.
Let me ask this question, but if you
so it has limit.
It has limits, but if you lose weight, let's say that you have a fibroid issue, and you lose weight, will that immediately make the fibroid go away? Does that happen once you lose weight? So you've already created this fibroid because you were overweight. Then you go and start taking GLP-1 and you begin to lose weight. Can that help resolve a fibroid issue without even having the UFE?
Well, the
Dr.Lipman question.
the fibroid's not going to go away. I mean, but you may improve your symptoms, certainly. That's a lot of our patients are trying that to see if that is going to improve their symptoms enough such that they don't need anything further. And for some women, that their symptoms aren't that terrible, it's going to improve their quality of life, not only their fibroid symptoms, but if they can successfully keep this weight off, it's going to improve their cardiovascular health as well. So I have no problem with patients using it, but I would caution for those that are looking for something. They're not a type 2 diabetic, they're not terribly overweight, they may be slightly overweight, and just rushing to something like this, and just simple caution. I mean, I've seen this before. there was a medication in pregnancy called thalidomide. And thalidomide, because when women were having, first trimester hyperemesis gravidarum, where they were throwing up constantly, and this medicine was the cure for that. There was a great enthusiasm for this medication. And then we found out there were a lot of birth defects, and now that, fortunately, that medicine is off the market. But sometimes the cure is worse than the disease, and just, you have to exercise caution. I think there are clearly people that benefit from these medicines, but I think further non-pharmaceutical produced studies for long term, I think, is where we need to be. A lot of the studies that are out are from the actual manufacturers of the drugs that have a very vested interest in seeing a very positive outcome. I think there clearly is benefits, but again, I want to be the caution here. I'm going to be the, on the other side of things to some degree, that, yes, excellent so far, but, pump the brakes a little bit, particularly if you're not that overweight.
I think you mentioned something too about the childbirth, and I want to really talk about that, because one of the things that I heard maybe 15, 20 years ago was that if I took vitamin D every single day, I would decrease my chances of breast cancer. I would also decrease my chances of having, dying on the table. What most people aren't talking about is that most African American women, when they're giving birth, they are afraid. Other women are afraid as well. I'm sure you were too, Dr. Angelina, but we are even more afraid because the numbers of death on the table are greater for African American women.
Absolutely.
So what are the actual numbers? Do either of you know, for African American women when they're giving birth, the difference between?
It's dramatic.
It's
I don't know
3
exact
to
number.
4 times that of the Caucasians.
Now, why is that?
Well, it's multifactorial. Number one, like I said, we talked about the obesity problem in a lot of African American women. So a lot of African American women are morbidly obese, which brings along its own complications and problems during pregnancy. As Dr. Lipman said, they're all vitamin D deficient mostly. And so being vitamin D deficient, you're trying to take care of two people, the baby and the mom. So the baby's going to basically siphon off all the mom's vitamin D, so the mom is vitamin D deficient. So a lot of the postpartum depression things that we see is like after they have their babies, their bodies are depleted of vitamin D. Being vitamin D deficient during pregnancy increases upper respiratory tract infections. It increases congestive heart failure, preeclampsia, eclampsia. 32-year-old Olympic gold medalist from the state of Mississippi, my home state, died this past summer from preeclampsia, eclampsia. She was an Olympic gold medalist. So,
Well, Serena Williams talked about her bout with that, right? She was afraid, and she said that the doctors just weren't listening to her. So I guess my question is, if a patient comes in and they're saying, I am in pain, this is bothering me, why would someone assume that it's a figment of their imagination?
I think there are cultural biases
But why?
that may influence that.
But why? What type of biases? I that's what I'm confused of. If a person says, I'm hurting, right?
Yes.
What is the bias? Why would an African American woman come into a doctor's office and say, I'm hurting, and she's not?
Well, the bias is that some doctors think that African Americans don't experience pain the same way. There's a different pain perception.
I just read something about that, Dr. Matthews. I saw, and it was actually a very well-respected physician. I can't remember his name, but he said he was actually taught in medical school that the threshold of pain for African Americans, specifically women, was higher. He said he was taught this in medical school.
Well, I've trained some students that actually told me that they were taught that, and I said, so I would just tell
Pain
them.
is pain.
Right.
I think it's the same teaching that teaches doctors that women don't have any feeling in their cervix, and so we can do all kind of biopsies and cervical things pain-free, and I'm like, try it yourself if you have one, it hurts. So there's a lot of push right now for that as well. So I think all of that was very wrong and how do you call it? I mean, I think it's discrimination. Even right now, not just African American, but just women versus men. You know, men will get full sedation, full vasectomy, but women are okay to get like full, almost half hysterectomy, that dramatic, but you know, without any lidocaine and nerve block. Get your IUD in and out without a nerve block, because there is no feeling there. It's all not true, but I think it's based on how medicine evolved in this country and the way it was taught and the way it was experimented all on African American females without any anesthesia. I think some of it is some women are more stoic. You know, somebody tried that on me when I broke my hand. They're like, "Oh, she's Russian. They're stoic. That you don't have to numb it up." I'm like, "Oh, try that on me.
So
You're gonna get your hand broken right here, right now."
Wow. I can't understand why someone would think a human would not experience pain like another human.
Well, it's part of a bigger issue. Obviously, there's a lot of racial biases and cultural things but as a patient, if you go to a physician, and we see this a lot in our practice, if you go to a physician and they ignore your symptoms, I commonly see patients that bleed very heavily each month, and they're just being dismissed as, well, that's your lot in life. You know, you're a heavy bleeder, women bleed heavily, particularly if you're suffering with fibroids, and that's just part of your normal. Well, if you're being ignored, if you're being dismissed, if you're having whatever the complaint is, you mentioned pain, but whatever it is, if you're not being listened to by your doctor, find another doctor. That's a simple thing. So you shouldn't have to suffer, you know, whatever it is. Find someone that, you know, is your advocate and will listen to you and will actually partner with you to a healthier, better life. If you're not getting that from your healthcare provider, find someone else.
Yeah, I agree with Dr. Lipman. I always tell patients that, and I'm sure Dr. Angelina
Same
agrees
thing.
also.
Find another doctor.
So the three of us always tell people, if you're not happy with that doctor, there are other doctors. It's like right at 1 million doctors in the United States. I said, choose another doctor if you're not happy. So not all doctors are like that. It's just a small segment of the doctors, but a lot of patients keep running into them. And so then if it's just totally, if you keep having problems with the doctor, like I said, just go to another doctor.
So is it true, though, that if I were to take vitamin D every single day, that could reduce or eliminate my chances of developing breast cancer?
Yes, Mayo Clinic put out a study saying that women with breast cancer should take vitamin D lifelong. So vitamin D is preventive. Actually, it's been the only thing that's shown to work in triple negative breast cancer in African American women. No other therapy works except vitamin D. And so it should be taken lifelong. It should be taken before, during, and after breast cancer.
So I'm sorry, Dr.
Well, just also fibroids. If you have a normal vitamin D level, you are much less likely to suffer with fibroids. And it's one of the reasons why African American women disproportionately suffer with fibroids. Only 10% of African American men or women have adequate vitamin D. So it's really important to get your vitamin D checked. It's so simple to supplement if you need to, and the degree of supplementation. So that's one of the things that we always talk in our practice about with patients. Make sure that they get that checked. It's something simple. It's definitely very helpful, and for other reasons as well.
You know, what's strange about that is a couple of things. When I go and have my physical, I have to request to have my vitamin D checked. And to me, it seems as if this is such an important attribute to help us with our health. Why is that not automatically included in our checkups? And also, it seems to me that no one has ever had that conversation with me about the importance of vitamin D. Even with my issues with fibroids, when I went to see my OBGYN, when I had the issues with my daughter, when I was pregnant with her, no one ever said to me, I've always breached the conversation about vitamin D to my physician. And I was even asked, why are you asking this question? And so that's just strange to me, that if it's so important into our health, why is that not already a part of your annual workup?
I think it's lack of education.
That and medical
But lack
school.
of education for our doctors?
Yes, medical school, we were not taught about vitamins A, B, C, and D. They just said eat 3 healthy meals a day. That's all they taught you in medical school. They taught you, pharmaceutical companies taught you how to prescribe medications. So most of your time is spent on learning how to prescribe medications, not doing preventive things. Like we know vitamin A is associated with night blindness. We know vitamin A helps steroid-induced wound healing. But all that stuff is not taught to doctors and stuff. So most doctors, once they get out of medical school, they just retain what they know. They're not doing a lot of independent thinking. They're not thinking outside the box or how can I bet on a patient population. If I asked 100 doctors, is vitamin D a hormone or a vitamin, probably 90% of them will say it's a vitamin.
I think
And soluble vitamin. And I think in medical school, the main thing we taught, obviously we taught about the how vitamin D develops in the body, how it goes, how it gets activated, sun exposure, kidney, there's a whole cycle for it. I think the most relevant thing you probably learn about vitamin D is with calcium deficiency and rickets and how African American population is more likely to get it if they don't get enough of it checked, like pediatric population. But if you doctor for adults, it really gets dropped off. So I think most of my vitamin D education comes from right here.
The question for me, though, Dr. Angelina, is why is it as an African American woman who's had some of these deficits that we're talking about in this room that I have never had a doctor say to me?
Because the doctor probably doesn't know about that.
Doctors, but I've been to doctors throughout the years.
Yeah,
Lack
they
of
don't know.
education.
They don't know. Same as right now, I get the same question about obesity. What does obesity cause? It's okay, just eat less, and you still get most of the doctors saying that to you. Lack
But
of education.
knowing that African American women naturally do not get vitamin D, and no one ever said. I just want you to see how that feels to me.
Oh, we know.
At the prime ripe age that I'm at now, I had to meet Dr. Matthews in 2020 and to open my eyes up about the importance of vitamin D.
Ebony, I worked at a medical school and with the OBGYN department in the same hospital on the 3rd floor. We were on the 7th floor, and I could not convince not one of my OBGYN colleagues to even test for vitamin D.
Let me ask you this question, and you guys tell me this, and this is no offense to the medical community, but I'm sitting here and I'm listening to what you guys are saying. And if you're saying that you're taught to prescribe medicine, have they created a field, when we call them doctors now, that are just high-level pharmaceutical salespeople now, that are responsible for pushing the medicine out there and not necessarily fixing the problem?
There's 2 ways to that, because I don't think I was taught how to prescribe medicine in medical school. We taught, there was a pharmacology class, we learned about medicine. Pharmaceutical companies were never involved in any of that. But yes, a lot of the Western medicine is really not going after the cause of the problem. It just symptom control. So in surgery, I think we're more likely to go after the cause because we're get to the bottom of it, let's cut it out. Let's take care of the problem, right? There's a cancer, we can cut it out. So there's also different fields and how they address different problems. So in surgery, we're more likely, well, you're a surgeon too. Same thing. You're a surgeon too. I keep pointing at you, but you're a surgeon too. So all of us are surgeons. So our primary thing, we can address the problem, right? If there's a breast cancer issue, we can go address the problem, and then we're gonna send them to medical doctor to try to, oncology to try to prevent it further. But
Dr. Angelina, let me ask you this question. The reason why I say that, I'm going in deep with it, because I'm just listening to what you guys are saying to me. Some of the more elaborate Christmas parties that I've been to of doctors have been sponsored by pharmaceuticals firms at their private homes or whatever. It's beautiful. We had some great times there.
I need some names.
Yeah, great times. Great times, like unbelievable times. But it just goes back to me thinking, is someone trying to fix my problem, or am I being doped up?
Well, the emphasis is certainly on when it's broke, and the emphasis really needs to be on the preventive side of things. It's if you really take the time and invest on the preventive side, it's going to be much less costly to society. But we have a system that, at least currently and in the past, has kind of been focused on, when it's broke, then you fix it. and not on the maintenance. It's like having a car and not doing the proper maintenance, checking the oil, doing the things to keep your car running. You just run it into the ground, and when it's broken, you show up to the mechanic and have them try to fix you. And so that is a problem, and it's getting better. We're getting more toward the preventive side and quality of care and outcomes for larger populations rather than individual cars that get broken. But it takes a long time to fix that system.
So as Dr. Angelina and Dr. Lipman said, we have a intervention system and not a prevention system. You know, we just treat patients when they come to the hospital and we need to do something to fix a problem. And then a lot of times, like Dr. Angelina said, we end up just fixing symptoms. We don't fix the actual problem. And so that is the way you're taught in medical school. You're just sitting there learning diagnoses and how to fix the problem. And then as surgeons, we're just aggressive in terms of we got a problem, we fix it and stuff. And so we move everything else out of the way and we're focused on fixing the problem at hand. So we don't just treat symptoms.
But is that the reason why so many OBGYNs just want to go and have hysterectomy? Like, to me, to just make the decision to go and slice up a woman, and there's so many other options out there. Is that a dangerous move for surgeons, just to say, I'm going to go in and just cut the problem out versus...
You get paid more money for hysterectomy than you do for vaginal delivery.
Going back to the pharmaceutical sales role.
Yeah, so there you go, to the sales role. But actually, as a contradiction to what you're saying, even though every one of our patients that walked through the door, ER graded, they got admitted to the hospital, got placed on our vitamin D protocol, every last one of them. There were some patients, told them, I wouldn't operate on you, a 100-year-old person with a stage 4 colon cancer that's in bad, poor health. I had some partners that would operate on a 120-year-old man in bad shape and poor health, and you're not going to improve their outcome with stage 4 cancer. So actually using the fix the problem preventive method, actually I was the biggest money maker in Morehouse Department of Surgery every year, even though I didn't operate on everybody, because they had more patients wanting to see me and requesting to see me because they knew I was going to do the right thing. I was going to try to fix the problem.
But is that the reason why you see so many people, Dr. Lipman,
we see a lot of people because they don't want surgery and they're not aware of the procedure that we do to save them from surgery if they're suffering with fibroids. But there's also the patient has to take responsibility here too. I mean, it's, we've kind of beat up the doctors here a little bit, and they deserve some of it, but there's also a patient responsibility. I can't tell you how many patients before I treated fibroids, when I was much younger in my training, post-training, I would treat patients with peripheral vascular disease, and they were typically very heavy smokers that got into trouble now. Now the blood flow to their legs was compromised because of their heavy smoking, and they wanted me to fix them. So they didn't have an amputation. They wanted me to do angioplasty or stent and improve the blood flow to their legs and their feet so they didn't get amputations. But what they weren't willing to do after I fixed them, they went right back and started smoking again. But even in recovery, sometimes they would try to sneak a cigarette. And so, there is patient responsibility is a part of this equation too. We can fix things and, do things, but, that's not the approach if the patient themselves is not invested in their own health. That's not going to be very beneficial to patients, certainly not in the long term.
No, I think that I'm glad that you said that, because I do think that many times it's easier to attack the experts in areas. You could have done more. You should have told me. You should have this. You should have that. And I'm totally anti the victim syndrome. That is totally anti how I believe in what I stand for. But I do think that someone should have said something to me before 2020 about vitamin D and how extremely it is important to me, because the light went off first when Dr. Matthews told me about it. But then further, when you came into the office, Dr. Lipman, and then you and I did a chronology interview, and then you said vitamin D. I said, wait a minute, I'm hearing it again. So I'm very perplexed as to why simple nutritional items such as that isn't included in the school systems, or at least shared more, I guess, freely, because it could make a big difference in one's life. But I definitely want to thank you. I think today's conversation was definitely one that was needed. I think it's the beginning of a conversation that we need to continue to have. I would definitely encourage you, if you have questions out there, concerns out there, as an African American woman in regards to your health care, definitely see your own physician, talk to your own doctor about your issues. But also, I would like to continue the conversation down below. So if you have comments or questions, please, let's tag the doctors that are here. Let's ask our questions, and let's continue the conversation. We will include their TikTok, Instagram, and Facebook handles at the bottom of this. But I definitely want this conversation to go beyond social media. I want it to be able to impact generations to come. Thank you so much for joining us on today's Doctor's Lounge.